Hi, thanks very much for having me speak about low carbohydrate diet and its impact on cardiovascular disease. This is a huge topic, and with the approval of the organizing committee, I've modified it to speak about low carbohydrate diet with respect to treating metabolic syndrome and type 2 diabetes. I have no financial disclosures. I want to start by acknowledging the support of Stephen Phinney, who's a professor emeritus at UC Davis, California, and chief medical officer of Virta Health. Dr. Phinney is a world-renowned researcher in the field of low-carbohydrate nutrition. He has published widely on this and has written several books on the subject. And he provided me with several of his slides from the two-year data on the Virta Health low-carb project, which you'll hear about more later. I also want to thank Blair O'Neill for providing me with some reference list material. Blair has become a clinical leader in the field of low-carb eating for benefiting patients with heart disease, and he lends a very credible clinical expertise to the subject. So who are we talking about to benefit from this dietary treatment? First, those with metabolic syndrome, characterized by high triglycerides, low HDL, elevated fasting glucose, elevated blood pressure, increased waist circumference. I'm also talking about patients with type 2 diabetes, which I like to think of as acquired insulin resistance syndrome. And you should recognize that because we measure glucose rather than people's insulin response to a carbohydrate challenge, we miss about 75% of people with type 2 diabetes. What is the low-carb diet or a well-formulated ketogenic diet? Well, it's more than bacon. This graph compares the relative portions of protein and carbohydrates in the different diets. The well-formulated ketogenic diet down here has about 10 to 15% of its calories from carbohydrates, with about 1 to 1.5 grams of protein per kilo. Contrast that with the paleo diet, which is also considered low carb, coming in below this 30% carb cut point, but higher in protein. The Mediterranean diet, similar protein to the ketogenic diet, but higher in carbs, running in the 30 to 40% range, compared to the standard American diet at about 50% and the Ornish diet in the 60 to 70% range of carbohydrate. What goes into the macronutrient composition of a well-formulated ketogenic diet or low-carb diet? We're talking 5 to 10% of the calories coming from carbohydrates, found in some of the protein that people eat, non-starchy vegetables, nuts and seeds, fruit, primarily from berries, and miscellaneous would include the carbohydrate found in high-fat dairy products. About 15 to 20% of the calories come from protein, and the remainder comes from fat. So how do you get into a state of nutritional ketosis, and how does that compare to ketoacidosis? Well, the very low carbohydrate diet of less than 50 grams per day induces this optimal ketosis state, which is somewhere between 0.5 and 3 millimolar ketones in your serum. Contrast that to ketoacidosis, which is a tenfold increase of ketones in your serum, which occurs from insulin insufficiency. People in a keto-adapted state have low levels of insulin, but not none, and that takes about 2 to 3 weeks to occur when you eat a 50-gram carb diet. During that time, patients will feel a bit tired, but around the 2 to 3 week mark, their energy starts to improve as they begin to optimally metabolize fat, and the ketones that they produce are actually used as fuel. Until recently, much of what we were taught about ketones was that they were simply a breakdown product of fat, and we knew little about them as a fuel source or the other benefits. In the last decade, there's been a fair amount of research demonstrating that ketones are an excellent energy source for both the brain and the heart. They also have a hormonal-like activity, mediating oxidative stress and inflammation. So let's get into the clinical, talking about low-fat versus low-carb diets for treatment of metabolic syndrome. This is a study published in 2009 with 40 patients. It was an outpatient trial running over 12 weeks, randomizing the patients to either low-carb or low-fat. You can see in the low-fat group, about 56% of the calories coming from carbohydrates versus only about 12% coming from carbs in the low carb group. I think something I want to draw attention to is that in the low fat group, they had about 12 grams of saturated fat in their diet compared to about 36 grams of saturated fat. This slide demonstrates the weight loss that occurred over the 12 weeks, with the low fat group losing on average about 10 kilos in the 12 weeks compared to about 5 kilos in the low fat group. You can see there was a large range in the low carb group, with a couple of people losing in the realm of 20 kilos over the course of 12 weeks. But metabolically, there were dramatic differences between the group. With respect to metabolic syndrome, we can see that the low carb group had superior results with loss of abdominal fat. Their triglycerides marked improvement compared to the low fat group. Much greater increases in HDL cholesterol here. There was improvements in ApoB lipoprotein, marked improvements in glucose compared to the low fat group, marked reductions in insulin, improvements in insulin resistance. And what I find very interesting is that even though the low carb group consumed 3 times as much saturated fat as the low fat group, their serum saturated fat level was substantially lower. When looking at the anti-inflammatory effects of low carb versus low fat, you can see that the low carb group performed better with reductions of IL-6, IL-8, tumor necrosis factor, monocyte chemoattractant factors, ICAM, selectin, and PI1. There were 7 biomarkers that did not differ between the groups. How quickly does this work? This is a metabolic ward study of 10 patients with type 2 diabetes, average age of 50, average BMI of 40. They were 3 weeks on a ward with a 7-day standard American diet, then followed by low carb for 14 days, consuming only 21 grams of carbohydrate per day. This upper graph here shows their glucose level over 24 hours. The black dots on the top represent their glucose during the 1-week run-in phase, and the blue dots, their glucose at the end of 2 weeks when they become more keto adaptive on the low carb diet. And you can see substantial improvements in glucose profile over the 24 hours. The lower graph down here looks at their insulin levels. The black as they 1 week run-in phase, and they were eating a standard American diet with high levels of insulin. And you can see after 2 weeks on keto adaptation, low carb diet, how much lower their serum insulin levels are. Over that 2-week period, there was a reduction in A1C, even though it was just 2 weeks. They had to reduce diabetic medications fairly promptly. There was a 35% reduction in triglycerides. Their weight dropped 2 kilos, and the patients reported reduced hunger. This next series of slides come from the Virta Health ongoing trial, looking at the effect of a long-term ketogenic diet on the management of type 2 diabetes. It's being run out of the University of Indiana. There are 262 patients who have type 2 diabetes. Their mean age is 54, mean BMI of 41, mean weight of 257 pounds. This is at entry to the trial. They've had diabetes on entry to the trial for 8.4 years, 67% of them female. And they're being compared to a non-randomized usual care population of 86 patients who are being treated in regional diabetic clinics in Indiana. Similar demographics, similar BMI. The intervention is a comprehensive clinic management of these type 2 diabetic patients. The patient follows themselves with continuous glucose monitoring, daily ketone measurements, all of which is loaded into an app and tracked by the health coach, who communicates with the patients by phone and by text for adjusting their meds and helping them through this process. There's a physician assigned to every patient who can work with both the coach and the patient through telehealth. Patients have access to a community group of other study participants where they can share ideas and issues that they have chat room, so to speak. The patients also have access to these resources of recipes and video guides, various teaching aids that they have for managing their care. So how does it work? This graph reflects the adherence to the program at 1 year, 83%, and at 2 years, 74% of the patients maintaining a state of nutritional ketosis. And this is documented by their daily measurements of their serum ketones over the course of the study. So highly successful in adherence to the program for at least 2 years. This slide represents the hemoglobin A1C in the trial patients compared to the control group over the 2 years. There was a 0.9% reduction in the hemoglobin A1C in the Virta Health group after 2 years, coming in at just over 6.5. This reflected a 32% improvement in insulin resistance. And in defining diabetes reversal as a hemoglobin A1C of less than 6.5% off all diabetic medications except metformin, 55% of the patients in the Virta Health group reversed their diabetes. I talked about their hemoglobin A1C improving by almost a percentage point. That occurred in the face of reducing or eliminating insulin use in 91% of patients. There was an average reduction of insulin dose by 81% in patients who began the trial on insulin. You can see here 60% eliminated their insulin completely, and another 30% reduced their dose. Sulfonylureas were discontinued in all patients who started the trial on them, and there was reductions in multiple other drugs across the spectrum. Of course, not every patient in the trial was using all of these drugs, but this shows the spectrum of medication reduction in order to maintain safe blood glucose levels. Following the keto adaptive diet results in a significant weight loss in the Virta Health group, dropping from a starting point of about 255 pounds to a weight of about 225 pounds sustained out to 2 years. By contrast, the control group increased their weight by about 15 pounds over the 2 years. This slide demonstrates the changes in atherosclerotic risk variables over 1 year in the Virta Health patients in blue compared to the usual care group in gray. And for sake of clarity, the authors have positioned improvements above the 0% line in the middle and worsening of variable effect below the line in that direction. The Virta Health group, by comparison to the usual care, showed significant improvements in small dense LDL cholesterol, ApoA1, and consequently HDL cholesterol, as you would expect. They see big reductions in triglycerides. We see improvements in large VLDL particle number. We see improvements in systolic and diastolic blood pressure and reduction in blood pressure medications. Big change here in high sensitivity CRP. White blood count improves, and their 10-year atherosclerotic risk calculation improving by 12% compared to the usual care. The only variable to worsen was the calculated LDL cholesterol. This slide, recently published, summarizes biomarkers of inflammation at both 1 and 2 years, the 1 year in blue and the 2 year in red. And it shows that 14 of the 16 biomarkers they used of inflammation improved in the Virta Health group over the course of the studies, and these were significant improvements compared to baseline. In summary, the low-carb diet outcomes show benefits with reduced weight, reduced BMI, reduced inflammation, reduced small dense LDL cholesterol and triglycerides. It actually has a significant effect on Lp(a), lowers blood pressure, lowers blood glucose, lowers insulin levels, lowers hemoglobin A1C and PI1, improves HDL, and improves the light buoyant LDL cholesterol. And the only variable that has produced any concern is the calculated LDL cholesterol. So in conclusions, a well-formulated, low-carbohydrate, ketogenic diet can result in safe and sustainable reversal of metabolic syndrome and type 2 diabetes over 2 years. And other than the calculated LDL cholesterol, which many feel is a weak predictor of cardiovascular disease, all other markers of cardiovascular risk improve on the low-carb diet. There are long-term studies that are needed for evaluating clinical endpoints. The serologic endpoints are really surrogate markers of improvement, but I believe those long-term study results will come. I'd like to recommend anyone that wants more reading on this to go to dietdoctor.com. It's a nonprofit, non-commercial website run by physicians who are interested in this subject. It has excellent resources and it's free. It's an excellent resource for your patients as well. If you want more scientific reading on it, there's a book published by Steve Phinney and Jeff Volek, which is also an excellent source of the history and the scientific literature supporting low carbohydrate living. So with that, I'm happy to answer any questions.